This is everybody.
About ready to go? Yeah, get started.
Guys, this is Dr. Maynard. CCB.
Morning, guys.
Your medical director. We're also going to have an associate medical director, which will be here in a little bit, Dr. Holland. And then on Friday's date, we're actually going to have Chief Lee Richardson from, where's he? He works for y'all.
Currently, yeah, he works for Best EMS, but he currently works for Parker County EMS. So he retired as a chief from Saxe Fire and decided that he didn't want to get off the box and decided to go play in Parker. So he's having fun out there.
So whatever questions y'all have, now's the time. I'm going to go through what's going to seem like a lot of big changes, but they're really not. But whatever notes y'all have or whatever, feel free to email them to me, call me. I'm planning on for the next 2 to 3 weeks being wide open for any questions or anything. If I don't have the answers, I'll work with Dr. Maynard and Chris and all of that to get everybody the answers that they need before we kick off June 1st and all of that.
All right, guys, so welcome to Best EMS. We're medical control for a number of different agencies. We'll talk about that more in a little bit. So excited to work together with you guys. Heard a lot of good things about this program. And so going to tell you a little bit about what it's like to work with us as medical control. We call that process onboarding. So we're going to be doing onboarding for all 164 of you guys, plus AMR coming on here in the future. So glad to have you guys here with us today as well. Please ask questions as we go along. Don't hesitate to just raise your hand, call on you, and we'll kind of just address things as it goes along. I know that change can seem like a lot at first. I want to make this easy. I want to break things down and make sure that this is all something that is doable. You know, a lot of us don't like the way that things are, but we also don't like change. And so we gotta have to, you know, kind of make the best of the situation. As you can hear in my voice, I'm a little bit under the weather, getting over a laryngitis. Lucky for you guys, I took a steroid shot yesterday and I got my voice back just in time. So if it sounds like I'm going through puberty again, that's why. Also, it's the power of drugs. So if anybody asks you, how's that new medical director? You can say, I think he was on drugs, you know, so at least steroids, right? Anyway, this presentation is going to take about an hour and a half. We'll probably take a break midway through. And just before we get into this, I just want to kind of get to know you guys a little bit better. So how many in this room are EMTs by training? Great. How many are paramedics by training? Great. Okay. And then advanced EMTs? Fantastic. So kind of a good mix. And how many are in that precarious situation where you're going to paramedic school but not yet a paramedic? Nobody? Oh, okay. I thought we had quite a few. Okay, great. All right, fantastic. All right, guys, so what do we expect today? We're going to go through a little bit about Best EMS. We're going to talk about me as a medical director and Dr. Holland, who's the associate medical director. We're going to get into the protocols and how we measure quality in our system. We're going to talk about airway and cardiac arrest, both traumatic cardiac arrest and medical cardiac arrest. One of the things we kind of pride ourselves on in Best EMS is we're really good at airway and we're also really good at cardiac arrest. And some of our ROSC rates are some of the best in Texas and also the best in the nation. We were going to do some high performance CPR skills. I think what we're going to do is just kind of talk about it today. We weren't able to get the mannequins and the infrastructure, but we'll be coming out next month for ride-outs, and we'll try to get everybody through high-performance CPR skills and talk to you guys a little bit about pit crew style CPR. If you guys are familiar with HP CPR, it's a pretty cool idea. All right, so a little bit about Best EMS. We serve over 60 different fire EMS and FRO agencies in the DFW area. We're expanding quite a bit. Growth has been quite a struggle. We've actually had to bring on new medical directors in order to get the demand covered. And we're made up of both physicians, ER and EMS physicians, and also paramedics and people from the fire and also EMS background. We oversee over 150,000 calls per year, so quite a few. These are a list of some of our agencies, and we can see we got some new folks on that list. Sorry, AMR, I didn't realize you guys were going to be here today. I didn't highlight you guys, but you guys probably see some familiar agencies up here. This is a little bit about our organizational structure. So we have a board. Some of you guys know or have met Dr. Fagan. They make up the board of directors. Our CMO is Dr. Justin Northheim. Chris Mussel is a guy that you guys have either met already or you will see around periodically. He kind of oversees all of our paramedics, and also, so we've got critical care. We've got the daughter of Dr. Fagan, Brianna Fagan, who's a rock star, and she's joined us in doing some administrative stuff, educational content, CE training, CQI. Lee Richardson, you guys, some of you will meet him on the last of the onboarding sessions. CQI, and then also Dr. Carrie Northheim, who does our research. And then down here underneath the CMO, we've got the rest of the medical directors. So this is me here, and then this is Dr. Holland, and both of us are going to be working together here at this agency. All right, so a little bit about our protocols. They are aggressive. Which is good. Some of you have been praying for this, asking for this. So now the time has come. We're going to be very aggressive. We're also going to start smart. We're going to lay a good foundation of the basics before we add a lot of aggressive things like ultrasound and vents and antibiotics. But those are all available to us if we, as an institution and leadership here, chooses to go down that road. Everyone can contribute. Okay, so this means the guy who just got hired yesterday and is an EMT can say, hey, this is what I'd like to see in the next revision of the protocols. The guy who's been here for 30 years and stone cold, paramedic, he can also give input, everybody up to, the chief. And so a lot of times what we'll do is we do revisions every 2 years in our protocols. Lucky for us here, we just completed the last revision, so those protocols are going to be released, and you guys won't have to learn an old version and then have it change in the future. So you guys will be good for the next 2 years on this new set of protocols. What we do is we basically meet and we collect all throughout the year. So if you have a revision that you would like to see in the next protocol, hey, I would like to have this added, I would like to see this different, send it over to Jimmy, he'll send it to me, and we collect these along the way over the next 2 years. And then basically we sit down in a big meeting. We'll send out the email, and it's a meeting that is in a big room like this. Every agency, anybody's invited, and usually 1 or 2 people come from each agency, and we just talk about it. People bring it up and we say, hey, we'd like to change this, and then we take that into consideration, and then there's a backroom conversation amongst the medical directors and the other coordinators, and we hash it out, and there's a lot of lively conversation about whether we should or should not make a change, and that's the fun part of this job. So also know that when we talk about evidence-based, this is based off of the most recent literature. We're usually either the first or near the first to move on new literature, which is exciting. Also, we want to make sure that we're not making changes and flip-flopping. So some of you guys are familiar with dual sequential defibrillation versus vector change for a shockable rhythm that's not, getting out of the shock, right? So we have a persistent VF. A lot of the literature says dual sequential is better, but then next month another literature comes out and says, well, vector change or just changing the position of the pads is better. So what we do instead is we say, all right, let's hold off, let's let the dust settle, and then let's make a decision once kind of there's consensus, so that we're not changing back and forth, because that's really hard for agencies to kind of flip-flop on something. What are we doing this month, right? So that makes sense. So also, we talk a lot with, all of us are ER physicians, and so we have a lot of colleagues that are experts in their field, whether it be OBGYN, oncology, diabetes care with endocrinologists, ortho, trauma, you name it. And so what we do is we talk with these guys and we say, hey, what are we doing in our local systems? We'll be meeting with the guys at regional and talking with them about what they expect us to do in the field, so that way we're all on the same page, kind of all playing off the same sheet of music. All right? So we offer a lot of education. CEs is part of what we treat. It's comprehensive. It goes through everything you need to know as an EMT or paramedic. And that is scheduled throughout the months. And we cover certain topics. There's hot topics that come down from the medical directors and things that we like to see. And this is kind of a collaborative effort, and this is usually taught by a paramedic. We also do advanced courses such as difficult airway, which is a really great course. I encourage you guys to look into that. Canine is a really cool course. It's not something that I think the average paramedic or EMT is going to be doing. But this is actually how to treat canine officers, not any dog in the field. just to be clear. I've had some med control calls. Hey, we got this dog that's impaled on a sharp object. Can we give him ketamine and get him off? I said, no, we're not treating these patients. That's not our patient. We don't have the liability coverage for that. It's only canine officers, okay? But it's a really cool program. They basically are working dogs, officers, and they have a vest and it has their medication list and dosages and all that kind of thing. It's a really cool program. It's a course you can take if you decided to do a program like that here. I don't think, do you guys have canine at Wichita Falls? Oh, great. Okay, so maybe we will be doing this. So if anybody's interested, a dog lover, and wants to get involved and be the paramedic, that's kind of the go-to on your shift, let us know and we'll get you involved, okay? POCUS, what's POCUS? It's nothing to do with witchcraft. It has to do with point of care ultrasound, okay? So that's point of care ultrasound. A lot of our, we have advanced ultrasound and then we also have basic ultrasound. Right now we don't have ultrasound at this agency, but if we want to, we can bring it on. See, these are all the kind of the things that we can kind of layer on top of the base that we're gonna build, okay? FTO classes, we kind of teach the FTOs how to be FTOs. It's a great class. And then also cadaver labs. This is actually how I lost my voice, speaking all day at cadaver lab. And that's a really great thing. We go in, we have 2 bodies that are fresh cadavers. These are not like, formaldehyde or formalin reserved. And we do it at UT Southwestern. We might talk about doing one up in this area so it's not such a long drive. I did that drive this morning. I know it's long. And so we could talk about how to do that. But cadaver lab is a great way to get more comfortable with procedures that are like what we call our halo procedures. So that's a high acuity and low opportunity. I mean, we don't get to do these procedures a lot. So your needle or your open crike, your finger thoracostomy, your pericardial centesis, and then like hard or difficult airway, and then using different airway techniques to feel more comfortable. But cadaver lab's always a hit. People have really good things to say about cadaver lab. All right, quality. We do annual protocol testing, and we'll talk to you guys about this more, but it's just basically a way to make sure everybody's up to speed on the protocol. We just have to way to track it. So we test annually, and within 3 months of coming on board, June 1st, we'll have you guys test for the protocols. We'll make sure that everybody's comfortable. Oftentimes we'll do a practice test and then we'll do the actual test. So you guys get an idea of the level of study. It's not something you need to worry about. It's something you do need to study for, just to make sure everybody's on the same page. And then we'll get everybody up to speed. Heaven forbid somebody fails. We go over the test with you, make sure that you understand why you missed the question, have you take it again. We use an online format called Impact EMS. And so you get all of the test questions online. You put your answers in, submit the test, you get your results instantly. You know if you passed or you failed, okay? There's no waiting, hours and hours or days and days. And then we also look at these questions on the back end and make sure that these are good questions based off of the data and analytics that we recognize in the system. Medical director interviews, MDI, not a metered dose inhaler, but a medical director interview. That is something that we do. So when somebody goes from EMT to paramedic or advanced EMT to paramedic, you'll sit down with me or Dr. Holland and we'll run you through some scenarios, skill scenarios. We usually do 3 cases and we just make sure that you're at the level that we feel comfortable with you, releasing you into the wild, okay? CQI, this is kind of ongoing, continuous quality improvement. So we look at things like code stat. I'll show you what that looks like. We collect data on what we're doing. I know I used to work in the field in EMS, and I know it's always a hassle to think that somebody's watching what you're doing. That's not the goal here. The goal is to make sure that we're meeting a minimum level. It keeps us out of trouble as medical control. It also keeps you out of trouble as a provider, providing care to the patient. And it also gives us an idea of what's the standard of care, because that's the measure that we're going to be judged on anytime there's a bad outcome. What were they following the standard of care, right? And this is kind of a legal but also a medical definition. And this helps us understand, are we practicing within that level of care? And we'll talk about what that means in a little bit. CARES, anybody familiar with CARES? It's a cardiac registry, and they look at cardiac arrest outcomes. We have some of the best CARES numbers in Texas in our agency. So when somebody goes down an agency that we provide medical control for, some of their cardiac arrest survival rates are upwards of 50, 60, some are even 70%. Pretty impressive, right? I don't know about you guys, when I worked EMS, right out of high school, we were doing cardiac arrest. I can't tell you we ever had a survival rate, right? The last 2 days, I worked in the ER. 2 of our best EMS agencies, one at DFW Airport, one at South Lake, brought me a cardiac arrest. There was really not much for me to do by the time they arrived because the patient had been resuscitated, got ROSC. One of the guys was smiling at me after his 4-minute cardiac arrest in the ER as I accepted him from one of our agency. I can't tell you how awesome this is as a medical director to have these kind of stories and then to sit with this guy and his spouse and say, you were dead earlier and because of these guys in the field, now you're alive. And that the gravity of that hits them, right? And then we do events where we reunite the crews with the survivors and it's incredibly powerful. And if that doesn't tug on your heartstrings or get you to tear up a little bit, I don't know what to tell you because that's why I do this job. That's the best part about doing this job. Seeing, because that could be one of your family members. And in fact, for those of you who live in this area, it might be one of your family members. So that's the gravity of what we're doing here. All right, so a little bit about me. So this is over in Melissa. We started the first ever in the nation eCPR. Anybody know what eCPR is? ECMO assisted CPR. All right, so what the heck is ECMO? You guys familiar with it? ECMO is extracorporeal membrane oxygenation. It basically bypasses the heart and the lungs. We give oxygen to the patient. They have these big giant cannulas that go into the femur and they basically take all the blood out, they oxygenate it, put it back in, okay? ECMO. Okay, so now we can do CPR with ECMO. And so this is a patient who required ECMO. This is actually a drill, so this is an actual patient. But this was a patient who met criteria to get ECMO in the field, but they're far away from the ECMO center. So what we do is we grab the patient and take them to the ECMO center. And this is the very first helicopter EMS eCPR in the nation. And we did it in our system, which is pretty cool. Haven't had a patient yet, but we're up and ready to go in Melissa. There's me with a survivor. So speaking of survivors, this guy in the teal, he went down. He was with his wife, who's this lady with the blonde hair, and he didn't want to go to the hospital. Stubborn old guy, right? Said, I'm having chest pains, sweaty, didn't want to go. And basically, the wife convinced him. They drove. They were going to my hospital, Baylor McKinney. Didn't make it. They pulled over at the Kroger. She did CPR on him. The medics got there and saved him, shocked him, got ROSC, got him to the hospital. And then I think 3 weeks later, he came and spoke at the opening, the push-in ceremony for Melissa's first ambulance. And so it's pretty cool. He's supposed to be wearing his life vest. He decided to skip it. And I said, you probably should put that on. It's got a life vest just in case he goes back into VFib. So. This is me doing one of those medical director interviews with one of the guys from Aubrey Fire. We're just doing a tabletop, scenario. Doing ultrasound here with some of the guys. Ultrasound again, you can see he's holding it with such pride there, that ultrasound device. If you guys want to see the ultrasound device, I've got one with me today. This is a really cool thing. So this is the chief at Aubrey Fire Department, and this is the EMS captain. These guys said, we expect all of our guys to take the protocol test online. We also expect them to go through the sit-down skills scenarios with the doc. We're no exception. We want to do it too. Come out and test us after we take the protocol test. They did great. 90% or greater on the protocol test, and they both did great on the scenario. So kind of leading by example, pretty cool story. All right, so we ride out with our crews as Best EMS. So you can see me there. We're doing a scenario here. We're checking off this guy here. That's why he looks so diligent taking notes. And basically, we're not there to criticize. We're not there to get people in trouble. When we ride out, the basic reason why we're there is we want to understand your system. Every system's different. There's this saying in EMS, if you've seen one EMS system, you've seen one EMS system. So every EMS system has a specific set of needs that are dependent on the community that they serve. So we don't expect that everything's going to be cookie cutter. That's why we need to customize. I don't understand the needs and the struggles that you guys have until I'm there in person. You could tell me, but being on scene is much easier for me to understand. when I'm there, I'm not trying to take over the call. I do this all day in the ER. I do it all the time. And if you want me to take over, I'm happy to. But for the most part, I'm there to observe and see how I can help so that I can make your job easier. That's the goal, okay? A lot of times people are a little intimidated. Oh, we got the ER doc here today. Be on your best behavior, right? And, you know, they hesitate. Hey, doc, sorry, sir, but do you mind just grabbing that IV for me? And I say, no, I got you, man. Yeah, absolutely. I'm there to help, guys. I'm not there to criticize or take over, okay? Everybody cool with that? Please, when I'm on shift with you guys, ask questions. Don't hesitate. A lot of times we've had some of the best conversations. I've learned things. I've had crews bring up questions and they'll say, you know, what about this and the protocol? And have you ever thought about, you know, changing this? And I'll say, you know what, that's actually a really good idea. We'll bring that up at the next revision. And we've ended up changing and implementing because there was a blind spot in the protocol. So we rely on you guys as well to make us all stronger as a result. So we're gonna be here one full day every month. On the even months, it's gonna be me. And on the odd months, it's gonna be Dr. Holland. You guys will meet later. A little bit about me. I grew up in California, in Southern California. Don't hate me. I didn't have a choice to be born there. I was born there. And went to Loma Linda University for undergrad, and then moved eastward to Arizona. Went to Midwestern University in Phoenix, or Glendale technically. Loved it there. A lot of good hiking and camping. And met my wife there on an OBGYN rotation of all things, and we delivered a baby our first shift together, so kind of a bonding moment. She's a PA. And then we moved eastward again to Texas, but I'm not going any farther east. This is the farthest east I'm going. And landed at Parkland in Dallas, UT Southwestern. That's where I did my emergency medicine residency. And a lot of great experiences there. Talk about learning about advanced pathology, people that waited too long to come in, and working with everybody from the president, you guys know that JFK was shot and then taken to Parkland, to the guy who's homeless on the street. More of the latter though, if you know what I mean. So. All right, Dr. Holland, I'm gonna let him tell a story when he gets here, but he went to all of these agencies or universities, and then he works at Presby in Denton. So. That's where he's based. But he's our associate medical director for this site, and you guys will see him around. All right, so medical control calls. This is the number. I would encourage you guys to put this into your phone now if you've got your phone with you.
So just to confirm, we're calling this for medical control and not in the hospital?
Correct, yes. The hospital may not be familiar with your protocol directly. We're going to try to get them up to date on the protocol, but you will call us 24/7, 365. We're always on call. So the way it works is you call this number, and let's just call it now to see how it works. So I've got it here.
Best EMS Med Control phone. For Dr. Northheim, press 0. Dr. Hancock, press 1. Dr. Holland, press 2. Dr. Maynard, press 3. Dr. Bertrand, press 4.
You don't have to wait. You can call. We're going to call Holland right now. Let's see if he answers, okay?
Hello?
Hey, Dr. Holland. This is Dr. Maynard. Now he's confused. Hey, we're just doing a demonstration for the guys.
Hey, what's up?
Hey, it's Maynard. We're just doing a demonstration for the guys. So just showing them how med control works. You're all clear.
Gotcha.
No question for you.
Sounds good.
All right, see you later, man.
I'll be there in a few minutes.
All right, see ya.
Bye.
All right, so just press 2. You're actually going to call Dr. Holland. That'll be your first. Press 2. If you wanted to talk to me specifically about something, you could press 3. But Dr. Holland's going to be first on call for this agency, okay? If you have a patient in front of you, call Med Control. It's a recorded line. We'll talk about that in a minute. go ahead and take down our phone numbers as well. Because if you have a need or something that you want to ask about that's not in front of a patient, that would be the time to use the text, okay? And just, be respectful about time of day. Not a lot of EMS medical directors are going to give you their cell phone number. We do it with the trust that you guys will use it appropriately. But a text would be a good way to start, unless it's a true emergency. You'd probably be calling med control line anyway, okay? So the way that I encourage you guys to put this into your phone is to say medical control as the first name, press 2 for Dr. Holland. And what that will do is that as you pull it up, it'll actually show you and remind you, so you don't have to wait for the whole thing. Now, when you call medical control, it'll ring to Dr. Holland when you press 2. If he doesn't answer within 20 seconds, it'll blast out to everybody, including me, and all the other 8 medical directors that are on staff with us. Somebody will answer, don't hang up, okay? A lot of times what people do is they press 2 for Dr. Holland, and then he doesn't answer in 10 seconds. They hang up and they go through the whole thing, and you're stuck in this endless cycle because maybe he's in a cardiac arrest at work and he can't take the call right now, right? Because he's doing patient care. So just let it keep ringing. Somebody will answer. We've never missed a call, okay? So just don't hang up. All right, so let's talk a little bit about when to call medical control. First thing I would encourage you to do is to have a question. It's hard to help if I don't know what the concern is, so start with the question. We call this BLUF, or bottom line up front. Some of you in the military know this term. So start with the end in mind. So what are some common medical control questions? Well, a patient wants to refuse, so start with Dr. Holland, Dr. Maynard, I have a patient that wants to refuse. Here's the story. So I know where you're going with it. Hey, Dr. Maynard, we have a patient who has a DNR, and they don't have the DNR with them, but all the family members say they have a valid DNR, they just can't find it. I'll tell you 99% of the time, unless there's something fishy about the situation on scene, I'm going to tell you just go with what the family says, as long as everybody's in agreement. And then we'll discontinue resuscitation on scene, because that's what the patient wanted, right? We're honoring the patient's wish. Oftentimes we'll get questions about, hey, we gave this patient fentanyl for pain, we give them ketamine for pain, we give them fentanyl again, we're maxed out at 3 doses. Can I get another dose of pain meds? Absolutely. Start by saying, Dr. Maynard, I need more pain medications. Here's why. We had a lady who fell. She's got a femur fracture. We gave her this, this, and this. She's still having pain. Blood pressure's still good. Can I give an additional dose of X? Yeah, absolutely. Sounds good. Termination of resuscitation. In our protocol, and we'll talk about this later, we have a way that you don't even have to call medical control and you can terminate on scene. Okay, and we'll talk about all the details. But sometimes that people don't fit into these nice black and white boxes. We know that life, especially in EMS, there's a lot of gray area. So if you need help, call medical control for termination or resuscitation, okay? And then the last thing is sometimes your question is just, man, can I get a second opinion? Happy to help. Just tell me that up front so I know where you're going with it. So tell me, hey doc, I got this patient, really complicated. I'm hoping to run it by you to get a second opinion. Here's the story, blah, blah, blah. All the confusing details, and then I will help you make a good decision in that situation. Does that make sense? But you must check before you call medical control. Take a pause, take a deep breath, gather your thoughts, and ask yourself, what is my question? Sometimes your question is just, I don't know what to do next. That is your question. Help me understand what to do next. But just start with the question, and then that makes it easier for us to know. Especially, I got drool on my face, sheet lines, waking up 3 a.m. I don't even know what my name is or where I'm at. And then I get this long tirade and I don't have any idea of where you're going with it. And then you ask a question that I wasn't expecting. And I'm like, wait a minute, what's going on here? So just make sure you ask the question up front. It helps me understand where you're going with it. Make sense? It's a recorded line. That means that it's recorded for your safety, because sometimes patients want to refuse, right? and they say, oh yeah, no, those guys at Wichita Falls, they came and they told me they were not going to take me to the hospital. Oh, actually, sir, I'm sorry, we have it on recorded line that you refuse transport. And then usually that complaint goes away, right? Doesn't happen often, but it has happened. So it's for your protection to make sure that everybody's on the same page. So anyway, I just mentioned that because sometimes people will use colorful language, and I just remind you, you're on a recorded line. So if you don't want it repeated later, just keep that in mind. So the question becomes, when do I call medical control? I would say if you're uncomfortable, then that makes me uncomfortable. So just call, okay? If you're comfortable with the situation, then you don't have to call. But that's just the general guiding principle I would use for this, okay? Questions on calling medical control? Yes, sir.
We haven't gone through the protocol yet.
Yeah, so you probably have lots of questions.
Maybe answer later, but you're not wanting a medical call on every refusal, are you?
No, no, we do not have to. No, it's more or less the patient you think really needs to go. They're hypotensive, they're tachycardic, they're hypoxic, they got a fever, whatever the case may be. You look at them, they're like, they're sick as snot. I want them to go to the hospital, but this stubborn old guy doesn't want to go. That's probably one to call, because now you're covering yourself with liability. Hey, we call medical control. Dr. Maynard, Dr. Holland spoke with the patient on speakerphone. We're all on the same page. The patient understands, and I'll tell you what I'm going to walk through when a patient wants to refuse in that situation. Sir, tell me the day. Tell me the president. Tell me why the paramedics are there. Alert-oriented times 4, right? And, sir, you understand that we can't assess you completely in the field. There's a chance you could have something dangerous that might even lead to disability or death, and you're willing to accept that as a possibility. Yes, I understand that. All right, repeat back to me what I just said. They go through it. All right, the patient has the key magic term, capacity to make medical decisions. I just don't want to go. I got bigger priorities in my life. I live a long life. I don't care if I die tonight. All right, sounds good. That's not suicidal. That's just letting fate take its way, right? That's an appropriate refusal. And I'm not going to force somebody to go to the hospital because legally I can't take them. Now, there's a lot of gray area here, right? Patient's intoxicated. Patient sometimes seems like they're making sense, but now they're not, and they're back and forth, and something might be fishy. That's what I'm going to say to you. Hey, what do you think we need to do? Do you feel comfortable leaving this guy on scene? You're probably going to come back in 10 minutes, and he's going to be a cardiac arrest. Can we take him against his will? And I'll work with you to make sure we're making the right decision for the patient. Sometimes we have to make decisions for the patient that they don't want. And that's just the nature of what we do. I would rather defend our actions of why we were more aggressive than the patient wanted us to be, rather than we left because they said no to transport and now they're dead. Make sense? But it's something we have to work out. And if the patient's completely with it and they want to stay on scene, that's up to them. Does that make sense? The details matter, right?
The way it was written, I just want to make sure.
Yeah, so it's not every refusal. Yeah, so this is just the common calls that we get, and it's usually gray area refusals where you're like, man, I don't know if we should leave this guy. And those are the ones that you can call on. You don't have to call on them. Yeah, you can refuse patients without calling medical control. That's most refusals are without calling medical control. Yeah, good question. Thanks for clarifying. All right, so within our system, we've got a couple resources. We have a Facebook page. You're welcome to follow us, but basically the reason why we have a Facebook page is a good place for people to see what we're doing, to see what other agencies are doing, and to help make sure that like we update classes and we kind of give kudos to people like when they pass their medical director interview, and we kind of post a picture of them and give them congratulations, those kind of things. We also have a website, bestems.org. It's currently undergoing a lot of revision. It's about to get way better, but it also has all the updated protocols. And so you can just click on your protocol, and then you can have electronic reference to it. We can also give you a digital copy of the protocols that you can keep on your phone. There's an app called Good Reader that you can download, and it's I think it's like $5 to get it or something. And that'll allow it to give access and also use the electronic hyperlinks that are within the protocol. Okay, so a lot of people like to use that. All right, so we were talking about quality and code stat. Anybody familiar with code stat? Have you guys seen this before? So physio control has a minute-by-minute cardiac arrest feedback. And what it looks like is you'll get a code stat result. So every cardiac arrest that we run will get a printed out code stat. And basically it'll talk about all the times and the turnout and the compression. It gives a color code. So here everything's green, everything looks good. Yellow, hey, we could use some improvement. And sometimes it's just a second or two, but it just fits into that category. We give you good feedback as well. It's not all negative feedback. And then some recommendations on how to improve. And then here's the really cool part. So this downloads directly from the LifeBack. And I know we don't have LifeBack 15s or 35s yet, but when they come, we can hook these up and do code stat reviews. And basically it tells you your compression ratio. So, hey, Dr. Holland, welcome. This is Dr. Holland, by the way. So we can say compression ratio, and this is basically the amount of time that we're on the chest. So only 4% of the time we were not doing compressions. That's what the compression ratio tells us. Compression rate, we know our goal is 100 to 120 beats per minute, or compressions per minute, and you can see they had an average of 102, so pretty good. So not only do you get this summary, but you also get a minute by minute. So this is when we turn the monitor on. And you can see we didn't do compressions until this point, and then it starts. These are every compression that we did. And you can see 127, 128, 129, and then right here, 102, 102. So either the guy got really good rhythm at this point, where the compressor started to get really good timing, or what do you think happened at this point? They put the Lucas device on, right? And that has perfect timing, so that's why it switched to 102, because that's what it was set to. And you can see the compression ratio was pretty good in here, 100%. They didn't come off the chest for a good 2 minutes. And then you can see here different interventions. These kind of purple or blue chevrons are breaths that they gave. And then you can see these numbers here tell us when the patient got intubation here. And then I think this is epinephrine or something else, maybe a shock. We can see the shocks delivered. Anyway, it's really cool. We can see a minute-by-minute breakdown of what happened during the cardiac arrest. Because a lot of times we fool ourselves when we think, oh man, that was a really good cardiac arrest because the patient had a good outcome. We look back and your compression ratio is way down in like the 60s. That should never be that low. We should be on the chest more often, minimizing interruptions. And maybe your beats per minute, right? You thought you were doing 100 to 120, but you're really down in the 80 range or something. So we can't improve what we don't measure. So that's why we use this tool. But a lot of guys like this. It becomes kind of like a game where they say, oh man, we're going to get better at this, and then we do get better at it. So data, these are the metrics that we follow, and these are all to try to measure excellence. These are unblinded, and we did that for a reason. So in the past, we had just published, like, for example, Keller's numbers, but everybody voted in our system that we wanted to unblind it so you could see where you stand in a comparable system, okay? So these are the things that we look at, things like your total calls, your refusals, and some places are gonna have high refusals. So if you look at DFW Airport, well, these people are traveling. A lot of times they refuse, so we know they're gonna have a higher level. But then here's our average, right? So they're above average, and that's okay, because that's just part of what DFW does. Narcotics, giving narcotics, and then getting relief, aeromedical. There's a whole list of these. This is just the first page, but there's a whole list of them. And again, guys, this is not to get people in trouble. This is just to understand where we stand and to be able to measure objectively how we can improve and get better and kind of meet the standard of care. And again, the goal there is that it helps patients, and also it keeps us out of trouble from a medical legal liability standpoint.
Are all these transport agencies? They actually have patient, they make patient contact and transport them to the hospital?
Most of them are. There's a few that are not. Yeah, and these are not all the agencies either. This is just the first page that I could fit onto this screen.
How is that going to differ from us from them?
It will differ, yeah. So some of the things like initial narcotic versus a repeat dose, and then there's a couple of the metrics that won't apply for FRO versus transporting. Yeah, and it'll be clear. You'll make sense of it. But the other thing is that the format of this is going to change too, and we're switching to this really cool data acquisition that is being implemented through our parent organization. And it's going to be really cool. You guys will have a dashboard, and we're hoping that it'll even be like somewhat live updates. So you'll be able to see kind of where we stand on certain metrics, and you just log into the website and find out. So it's going to be pretty cool. We're really excited about it. We were talking about CARES earlier, Cardiac Arrest Registry to Enhance Survival. This is something that's done out of UT Houston. And basically what it comes down to is what's called a Utstein score. I always thought Utstein was like an acronym. Are you guys familiar with Utstein score? Okay, so this is just a common terminology that we use in cardiac arrest literature to let us know apples to apples comparison. So this is somebody that bystanders did CPR on. It was VFib arrest. And then they got ROSC and a good neurologic outcome, okay? So these are the patients. And you look here, Grapevine Fire Department, 66% Utstein bystander survival rate. That's really impressive, right? So these guys are doing the things that we recommend. This is one of our agencies, and they're getting great results.
And the Utstein is actually, it was where this was first kind of discussed and developed. It's actually out of the Utstein Abbey in, I believe, Belgium is where they actually met. So
I think, yeah, Norway or Scandinavia somewhere.
Yeah, it was somewhere up there, where it was Utstein, this is where they all got together. They decided to, after the conference, decided to do research and produce policy moving forward to try and improve this.
Yeah, I thought at first Utstein or Utstein stood for something. It was like an acronym. It does. It's just, yeah, it's like somebody's abbey over in Scandinavia somewhere. So don't be, anyway, the main thing to remember is that these are like our best chance of survival. Witnessed, bystander CPR, shock delivered, and then they do well. These are the patients that walk out of the hospital and then shake our hands later at a survival celebration kind of thing.
And with the high performance CPR too, that's based out of Resuscitation Academy in Seattle, it's that same thing. Is they're the best in the world at out of hospital cardiac arrest with VFib, that they get ROS back. It's the same template.
Yep. All right, and then, so this is actually a survivor. This guy went down at the Lifetime Fitness. He was working out. A guy next to him said, that guy doesn't look right, called for help, started doing bystander CPR. They shocked him. And actually, Chris Muscle here was on that call. And he said, man, this guy, I tell you, he had no life in him. He was dead as a doornail. And they ended up shocking him a number of times. They ended up having to pace him afterwards. He was waking up. You can see he's a guy that works out. He's kind of a big muscular guy. And he called me on med control, so I was partially involved in this call. And then a couple days later, we got to go to the ICU and meet this guy. On the same day, it was a Monday, this guy and another guy both went down in McKinney. Both of them survived, and we got to meet both of them on the same day in the ICU, one after another. Incredible, right? So these are the type of stories that we're seeing in our system because of the systems that we're implementing, right? So I just want to encourage you guys, I don't know what our survival rate is here or what it's going to be, but I can tell you what we're seeing in our system, and if you follow the plan, it's really impressive. And when you meet a guy like this, and he's with his dad, and his dad is in tears, because he says, I'm the one that's supposed to be in cardiac arrest, not him, right? And you guys saved him, and he's tearing up. I mean, it's incredibly powerful. This me and Muscle riding out together on a ride-out day. We're in the kind of the BC vehicle, going to catch calls. Always busy. Muscle's a total black cloud, so it's always fun to go with him. This is me teaching how to use a rigid stylet. Every once in a while, I get to play with some of the cool tools and like doing that kind of stuff. So y'all can teach me something about firefighting and extrication. Right out here, this is one of our FTOs, Chase Eller. All right, so a little bit about protocols. Basically, they're all in sections here in the protocols. This is what our protocols look like. They've got these quick buttons here that you can use to go back or go to the table of contents. But if you click on DNR, you'll take you to that section. So it's kind of nice where you click on it and you're already there. Yeah, obviously, if it's printed out in paper, it doesn't do that, right? But if it's an electronic version. So these are the different sections that we have. General information, that covers all of this kind of stuff here. General information, patient assessment, medical, pediatrics, trauma, skills, and medications, okay? That's all of our protocols. Okay, but obviously the details are expanded in each one. All right, so I'll pause there. We're going to get into some more kind of lecture style stuff with talking about airway, and then we'll talk about cardiac arrest. But any questions about Best EMS, CQI, classes, protocols? I know you guys haven't seen the protocols. Probably have 1,000 questions about them. But anything that comes to your mind right now, if you've got the question, somebody else probably is thinking it too. All right.
How do y'all integrate with our ER?
How do we integrate with it? Well,
That's a great question. Have you been to United Regional?
not yet. We'll cross that bridge when we come to it. Yeah, these are the things that I need to know because there's no way for me to know about questions or concerns until we do it. But I can tell you, it's not uncommon for even in the DFW, in the Metroplex, for EMS to lead the way and do things that the hospital's not yet doing, like dual sequential, like pre-hospital antibiotics, like ultrasound in the field, like pre-hospital blood. We're doing these things because it's right for the patient. If we get pushback from the hospital, it's not your job as a frontline medic or EMT to fight that fight with the nurse at bedside. You tell them respectfully, this isn't our protocol. We practice under a medical director. I'm happy to give you his contact info, and you can talk to him about why we're doing what we do. Also, if you don't understand why we're doing what we do, then talk to me, talk to Jimmy, talk to Dr. Holland, because if you're not convinced we should be doing this, then we're not all on the same page, right? And if I can't convince you this is why we're doing this, because of good patient outcome, it's the best thing for the patient, it's probably what you would want done if it was your family member, then I'm not doing my job. So I always tell my agencies, I'm the why guy. If you don't understand why we're doing something, then I'm not doing my job. But I don't know I'm not doing my job until you tell me. So you got to tell me that you don't understand why we're doing this. Hey, this sounds stupid. Why are we doing this? Talk to me. I won't be offended. And if I can't explain it, then we probably shouldn't be doing it. Make sense?
Yeah, the ideal situation is yeah, you guys are working with Best EMS, you're under Best EMS protocols, you transport to an ER where a Best EMS physician works as an ER physician. That's the ideal situation. How often does that actually happen? Is that ideal situation set? Not that often, right? So we liaison with, like Dr. Maynard said, we liaison with different ERs, with different hospitals, with different administrative leadership. That's a very common situation for us. So if there's something that needs to be brought to our attention or something that we need to liaison with, don't hesitate to bring that up. That's why we're here.
Yeah. That is just part of the job for us, is taking complaints, taking what sounds like an inappropriate paramedic intervention or EMT intervention, and then explaining why they were within protocol. Now, I can only cover you if you're within protocol, right? So we got to know our protocols, and that's why we study and we know the protocol. But if you're within protocol, I'm going to back you up 100, and I will fight. I will have your back against anybody who tries to come after you and say it was substandard care, because these protocols have been reviewed by hundreds of physicians from all different specialties, and we have looked at it from all of the evidence, and so these protocols are sound. It's going to be different though, and nobody likes change. And when you come in with a patient and you've given a medication that the nurse has never even heard of, right? They're going to say, hey, what's going on here? Like, why did you guys give this, right? So that's fine. We'll cross that bridge when we come to it. All right? Or as my grandfather used to say, we'll burn that bridge when we get to it. Just kidding, we're not gonna burn a bridge. All right, let's talk about airway. So we have this saying in EMS, resuscitate before you intubate. This is really, really important. You're gonna hear us say this over and over again. When you are given a laryngoscope blade, you're given a license to kill. Literally, you could kill a patient if you do not intubate them properly. Now, I know a lot of you are not gonna be intubating, but you can also spot when a patient is not ready for intubation. They're still hypoxic or they're hypotensive. Those are the two vital signs we're gonna look at, and we'll talk about that more in a bit. But we wanna make sure the patient is ready to receive the ET tube, and if they're not yet ready, we've got some work to do to get them to that point. So we're gonna resuscitate them before we put the tube in the trachea. Don't put it in the esophagus. All right, so we're going to move away from rapid sequence intubation and move towards resuscitation. So now we call it resuscitation sequence intubation. That's what RSI now stands for. Difficult airway plurals. We're going to use the head of the bed, keep it elevated. That helps put the lungs in a good position, also decreases reflux from the stomach and aspiration. Optimize the BP and the SATs. I'll tell you right out, the BP should be greater than 90 if we're ever intubating, and the SAT should be greater than 94%. That's in the protocol. That's our goal. Now, you can get it higher than that. That would be better. You want as much cushion as you can, but that's kind of the minimum that we're shooting for. All right, if the respiratory rate is normal, there's no reason to bag the patient. You're probably just going to add more air into the down the esophagus into the stomach, and so just provide oxygen. That's all you really need to do. Everybody that's about to get intubated should have a non-rebreather mask if they're breathing. If they're not, a BVM, and then a high flow nasal cannula. All right, so let's double click on this for a second. So high flow nasal cannula, there's two types of nasal cannulas that we'll get to know once we get the life packs and we get end-tidal CO2. But there's a small one that has very narrow prongs, and that can only go up to 6 liters. And then we have the traditional nasal cannulas that can go up to, typically it's, 6 or 8 liters, but we can crank it all the way up to 15. And we want to do that before we intubate. It's uncomfortable, but it's only for a short time until we intubate. And we leave it on during the entire intubation attempt, and that's called apneic oxygenation. The patient's no longer breathing. We can still oxygenate through that high flow nasal cannula, okay? Guys, stop me if you have questions, okay? Non-rebreather mask, flush rate, okay? And we'll talk about what flush rate is. Anybody know what flush rate is? So what do you normally put your non-rebreather mask at? How many liters per minute? Nobody knows? 2 liters? You'll suffocate the patient. 10 to 15. Thank you, sir, for speaking up. So 10 to 15. And what FiO2 does that produce, roughly? It's about 70%, okay? Now, you guys have seen those, Christmas tree looking regulators, right? They've got the little ball that goes up. It usually goes up to 20. How high can it actually go? If you keep turning that knob, take one off the wall next time you see in the ambulance or in the hospital and look on the back of it. They go up to 40 liters per minute at flush rate. Flush means you've turned it all the way up, right? It's kind of like a spinal tap, right? It doesn't go up to 10, it goes up to 11, right? So all the way up until it won't turn anymore. And that gives you 40 liters per minute. And that's what you want it at, flush rate for your non-rebreather or your BVM, okay? Some of this is going to make more sense as we review it over and over again and practice it. All right, so the patient has a pulse. You need to use induction and paralytic. So, rocuronium for paralyze and also ketamine for induction. All right, there you go. We're getting away from Versed. What are you guys using for intubation?
We use intubated rock, but I've been using ketamine rock.
Ketamine and rock, great.
So we have ketamine, we have an etomidate,
Yeah, etomidate would be fine too.
and then we have sucks, rock, and deck. But most of the time I use ketamine and rock.
Love it, that's what I use too. It's kind of my go-to. Rocuronium dose, you could go up to 2 mgs per kg. Usually takes about 60 seconds. When you're giving it at 2 mgs, it's pretty fast onset, pretty much equivalent to succinylcholine, which technically has a faster onset. But if you give rock at a higher dose, also remember that if the patient is hypotensive, it's going to take a little bit longer for this to kick in, okay? Always suction before your video laryngoscopy blade, okay? So we kind of call this like, clearing the way or putting the snow plow in front of your car, so that way it clears the way of all the secretions. And are you guys familiar with the salad technique? Have you guys heard of that? Yeah, good. So this is basically where we are decontaminating a contaminated airway. What is a contaminated airway? Secretions, vomit, blood, and we basically are just leaving the suction in the esophagus off to the left side of the patient, and then that way we can VL, and any additional vomit hopefully will be taken up by the suction. Sometimes the smaller patients, a lot of big things in a small area, so just keep that in mind. study after study have shown that video is better than direct laryngoscopy, okay? So we really push for VL over DL, and the success rate is better. We find that your first attempt is always your best attempt, and the research would support this. So when you intubate and you fail, it happens, you kind of gum up and beat up on the cords, and then they swell, and the next time you go in, the anatomy is distorted. You try to push it through, and now it won't go through, right? So your first attempt is always your easiest and your best attempt. So set yourself up for success. You know, this is one of those times where you go slow, it becomes smooth, and then smooth is fast, right? You want to put the tip of the blade in the vallecula. That's right at the, where the tongue meets the base of the epiglottis. Rigid stylet is good if you're using a hyperangulated VL. What are y'all using at AMR for VL? Are you using VL?
Yeah, so we've got, I don't remember what these new ones are called. They're like that. They have
Okay. Yeah, this is the UE. No. UV. What is this one called? The UE, I think.
The one scopes, yeah, that's right. And
Oh, okay, yeah, it's similar, very similar.
The ones that don't have that are using King Visions.
Okay, so King Vision and One Scope. Yeah, One Scope is very similar. I like the One Scope. This one I think is a little bit cheaper. And anyway, video, and they have both the regular geometry blade that looks like a Mac, and then they've also got the hyperangulated. Anyway, so that's the background for those of you that are wondering what we're talking about. If it's hyperangulated, it's really hard to get around that corner with a bougie, and so using a rigid stylet helps you get around that corner, okay? We'll do specific training on this to make that make more sense. All right, so what is safe apnea time? It's basically the time when the patient stops breathing until they drop down below 90%. It's really important to know this because this is our time to intubate, right? The patient stops breathing, we're gonna drop the tube. How much time do you want in order to place the tube? You want a lot of time? You want a little time? No one ever complained about having too much time to intubate. So we want to set ourselves up for success so that we have lots of time to intubate and the patient never drops their sat during our intubation. Remember, we talked about earlier, you're given a license to kill the patient. You're going to make them stop breathing by giving them a paralytic. So you want to make sure you top up the tank. They have as much oxygen as possible in their system before we make them stop breathing, because now the pressure's on us. We got to get that tube in, because if we don't, what's going to happen? Either you're going to have to bag the patient, or if you can't bag the patient, now they're in trouble. So it's really important that we do this the right way the first time. All right, so what affects safe apnea time? Things like body habitus, right? We've all seen that patient, giant neck, they look like they're using the CPAP at night. Age, right? Have less reserve when you're younger and when you're older. Comorbidities like COPD, asthma, they're going to decompensate faster, and how sick they are, right? And then their oxygen reservoir is basically what these all come down to. All right, so what does this look like? This is a really handy graph here. So let's look at a normal patient. So just to kind of get your bearings, this is time. This is up to 10 minutes over here, and this is the O2 sat. So you got a patient that starts out at about 100, and then how long does it take before they hit 90? Well, that's about 8 minutes for a normal patient. I don't know about you, but 70 kilograms is not normal anymore. I think more is like 100, but anyway, I digress. All right, so let's compare that to an obese patient. So they start at 100, and then how long does it take for them to get down to 90? Oh man, way shorter, right? It's like 2.5 minutes there. So keep that in mind. How long do you want to have to intubate? 8 minutes or 2.5 minutes? Let's make this an adult who is, all right, let's do a child now. So child, 10 kilogram child, they're going to decompensate and then reach 90 at about 3.5 minutes or so. So remember, they stop breathing and now their oxygen's going to drop. And you can see how it drops. It doesn't just go down in a straight line, right? It kind of goes, gets down, and then it kind of falls off the cliff, right? That's how pulse ox goes. And usually, once they get around, 90%, that's around the time they start to really fall off the cliff and decompensate quickly. So if you're starting to see it drop, you better be more aggressive to get that sat up, because if we don't If we're not aggressive, we're going to miss the bus, and the patient's going to get worse. They're going to go into cardiac arrest, and then we're playing catch up, and we don't want to do that. We want to avoid that. All right, so what if they're ill? So now they're going to start at a pulse ox of, let's just like 97%, and when they get down to 90, that's about 5 minutes. Anyway, these are just examples to give you an idea of how these affect our safe apnea time. Now, if a patient becomes hypoxic less than 90 during your intubation attempt, why do we care about this? Well, guess what? You just doubled their risk of going into cardiac arrest during intubation. Remember, I told you, you have a license to kill. They had a pulse before you started to intubate. Now they don't have a pulse. What made the difference? Your care. So let's make the care help the patient, not harm the patient. So we have to realize the gravity of what we're doing. All right, what are we breathing right now? About 78% nitrogen, 21% oxygen, the rest, a bunch of other gases we don't care about. So what do we want the patient to be breathing before we intubate? As much of this as we can, oxygen. So how do we do that? Well, I'd ask you, what's the maximum SpO2 that can be obtained? You get a pulse ox. What's the highest number you can get? It's not a trick question. 100%, right? 100%. Can't get any higher than that. Can't get like 110% pulse ox. All right, what are we measuring when we're measuring the SpO2? You guys put this on people all the time, right? We should know what this, it's good review, right? All right, I'll help you out. Hemoglobin is either attached to oxygen or it's not. When it's attached, we count it. And the percentage of hemoglobin that's attached to oxygen gives us our percentage of SpO2. So 99% of the hemoglobin is attached to oxygen in this patient here. Everybody with me? Everybody agree? Of course, there's false positives, carbon monoxide poisoning, all those kind of things, cyanide poisoning. We're going to put those to the side for now. All right, so the highest you can get is 100%. Now, it may sound like a trick question, but it's not. What's the highest amount of oxygen that can be dissolved in the blood? Has anyone ever seen an ABG before? Gives you your pH, your PCO2, and your PO2. Wait a minute, what is this number? That's above 100. Because it's not measuring in a percentage, it's measuring in pressure, millimeters of mercury, right? So the oxygen pressure, the partial pressure of oxygen is what PO2 means. And this is something that's seen on a ABG. And so when you get a patient up to 99%, 100%, you can actually even go higher than that in terms of the dissolved oxygen in the blood. Now, this additional oxygen is not attached to hemoglobin, but it is in the plasma and the patient can use it. And we can help increase our safe apnea time by increasing the oxygen. So once you meet 99 or 100%, your job's not necessarily done. You can even get it better than that, okay? So just remember, but you're not going to be able to measure it unless you do an ABG, and you're not going to be doing ABGs in the field. Everybody with me? All right, cool. All right, so you can actually get above 100. So normal is like 80 to 100, but you can actually get higher. And in fact, like on patients that we intubate and we do an ABG, they're on 100% FiO2 on the vent, we'll get, you know, like what's the highest you've seen? Like 800 millimeters of mercury, right? Really high. But their pulse ox is 100%, right? So this is beyond pulse ox, because I'm not talking about a percentage anymore. This is, all right. And I only say this to get the concept in. You're not going to be measuring these things, right? It's just to get the concept down. All right, yeah. So fill up the tank and prolong your safe apnea time. That's the take-home message. If you only remember one thing about all this rambling is once you're at 100%, you could still do better by increasing. All right, so now my question is, how do we do that? All right, how do we increase our safe apnea time? Well, we know these things like from paramedic school. So like a non-rebreather mask, remember we talked about at 15 liters per minute flow weight, it only gives us about 70% FiO2. These are your standard numbers. But, and look at this, bag valve mask, leak or without a one-way exhalation valve, less than 50%. We don't want that. We want as high as possible. So this is kind of like your patient's alive, They just need a little oxygen. This is what we're gonna do for them. Now let's make them sick, and let's talk about how to increase it. High flow now. These other ones were, low flow or low FiO2. Now let's talk about how to do high flow. So if we do a non-rebreather mask, remember we talked about flush rate, right? So this is above 15 liters per minute that we said we would set it at. Now we're gonna crank it up all the way as high as it'll go. It's gonna sound like a jet's taking off in the room, right? Shh, that's fine, that's what we want. And that'll give us 100% non-rebreather mask. A high flow nasal cannula, we can get up to 40 to 60 and give 100%. And remember, we said we're gonna do a nasal cannula at 15, because it can be really uncomfortable for a conscious patient to have it any higher than that. And then in addition to that, on top of the cannula, we can put a non-rebreather mask. And you can bet the patient's gonna get at least 100% FiO2 with that combination. And then the advantage is that once you take the mask off, and then you give your induction and paralytics, patient stops breathing, but they're still getting oxygen through the nasal cannula via passive oxygenation, okay? You guys with me? Okay. These are the numbers to remember, okay? These are your goals. Your blood pressure, systolic, should be greater than 90 before you intubate the patient. Your pulse ox should be greater than 94% before you intubate the patient. Now, the nice thing is that we still use these numbers for other things too. So we say stabilize the patient on scene. All right, so the old mentality in EMS, this is a sick patient, load them and go, get them in the back of the unit, right? The problem is in these patients code as we're moving them down the 3 flights of stairs from their apartment, right? I know you guys don't have those patients, right? You probably do, right? So when we recognize a patient who is unstable, we say, stabilize before you mobilize, okay? Because moving a patient is a stress, and we'll talk about some of those patients in a minute. But if you have a patient who's teetering on disaster, whether it's their pulse ox that's about to go down that curve, right? They're 88%, they're about to become 50%. Whether their blood pressure is at 90 and then it drops down to 50 and then they go into cardiac arrest. We don't want to add a stress. You say, Dr. Maynard, you're saying not to move the patient? That's going to cause a stress? Have you guys ever had a patient that's so short of breath that even getting them to move from the bed to the gurney causes them to decompensate, and then they have to catch up their breath for the next, 10 minutes? They have no reserve, guys. So we have to keep that in mind, that if we're going to cause a stress to the patient, we need to make sure that we are doing it appropriately. All right, so we stabilize, meaning we make these numbers better before we move the patient. I can't tell you how many times we'll get a CQI and the patient's blood pressure and pulse ox were borderline. They move the patient because everybody got excited. Got to get this patient out of here. Got to get in the hospital. Got to go, 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 go. Load and go, guys, load and go. We're not doing that anymore. We stay on scene. We stabilize the patient. When they're stabilized, you get better outcomes. There's nothing that we're going to do in the ER that you can't do on scene for most of these patients, okay? All right, this is our scene movement guidelines. So this is, how to access the patient. If they're stuck between the toilet and the bathtub and you can't access them, well, you got to get them out of there. So you got to move that patient, right? So that's an exception. But for the most part, we want to get access to the patient, 360-degree access, and then here's our goals. And you can see here, pulse ox 94% or greater. Now, we just learned that once we get up to 100%, we can get even higher, especially if we're about to intubate. We want to get them as high as possible. And then our blood pressure. And this is if they're pediatric, 70 plus 2 times the age. All right, anyway, we're not going to spend too much time on this other than just remember, we want to avoid causing harm to the patient by moving them when they're critical, their blood pressure and their pulse ox are borderline. But also use your judgment, right? I mean, if it's not safe, right? You got a patient who's hypoxic, hypotensive, they're on the side of the road, and you got semis running by, right? You don't have any coverage, right? Get out of this unsafe situation, right? You're not, risking your life to help this patient. You're going to do the right thing at that time. All right, let's do some cases. All right, you got a 75-year-old female at home with family, altered, decreased mental status for 6 hours. Here's her blood pressure, heart rate, respiratory rate, room air sat, end-tidal CO2, febrile, and glucose is 250. What do you guys want to do for this patient? Load and go? No, we're not loading and going anymore, right? So what are some things we need to address before we can load this patient up? O2 sat, great. How are you going to help the O2 sat?
You can do a nasal cannula or non-rebreather.
Great, love it. What else? Blood pressure is probably my most concerning thing. High heart rate, low blood pressure tells me this patient is in shock. So their blood pressure drops for whatever reason. There's multiple times of shock. I don't know what type of shock yet. I just know they're in shock. And so I need to give them fluids to get them a higher blood pressure, and then their heart rate will naturally come down because it doesn't have to work to make up for the low blood pressure. All right, what else?
Fluids.
Yeah, fluids.
Her mental status sounds like she's got a UTI.
Could be a UTI, right? With a fever, tachycardic hypotensive, right? Low end-tidal CO2. What we'll learn as we go through and learn more about capnography and end-tidal CO2 is that it's a marker of poor perfusion. From what? From anything. Septic shock, hemorrhagic shock from bleeding into the belly, bleeding out, right? GI bleed. All right, so here's what I would say. I would give O2, fluids, and probably give push dose epi. I know we're not doing that yet. We'll talk about how to do it. A lot of the things that we're going to talk about today are not things that we're doing yet. Although, AMR, you guys doing push dose epi?
If they're dead.
Oh, okay. Well, that would just be full dose epi, right? Okay, push dose epi is giving small micrograms of epinephrine to the patient, raises their blood pressure and their heart rate. You also get a little bronchodilation, but you're giving epi in smaller doses because the patient is alive, but they're hypotensive. And so we're gonna bump their blood pressure up.
So I guess that would be IV.
Yeah, that would be IV, correct, yeah.
You're talking like 30 epi, where you can mix it in with fluids and titrate it?
We don't do dirty epi in our system, but it is the same idea. We're giving a smaller dose of epi, but just pushes.
You're controlling it.
Yeah, I'll tell you the easiest way to do an epi push dose is you take an epi syringe, your normal cardiac vial, the tan box, right? Push all but 1 ml out. Then go to your bag and draw up 9 cc's, and now you have a total of 10 cc's of fluid. Each milliliter of that is 100 micrograms of epinephrine. And so every few minutes you can give 1 to 200 micrograms. And you'll see it works really fast. Blood pressure starts ratcheting up. You get them to a place where now their blood pressure's higher, their heart rate might go up, that's fine. And now they're safe to intubate. In addition to the fluids we're gonna give them too, okay? Anyway, you guys don't have to worry about push dose epi, just if you're curious, wanna let you know. All right, here's another case. 35-year-old, back of the grocery store, peanut allergy, short of breath, allergic reaction, rash, wheezing, vomiting, altermentation. What's this guy got? Anaphylaxis, all day, every day. Oh man, really anaphylactic, right? I don't like that. He's vasodilating. He's got leaky blood vessels from this allergy. Tachycardic, SATs are low. He's probably got some pulmonary edema, cutting off his airway, who knows, right? Shark fin, what does that tell me? End-tidal CO2 shows a shark fin. It's an obstructive pattern. And we'll talk about this stuff. I'm just giving you a heads up. You guys will get the answers to the test in advance. No fever, and the glucose is normal. All right, what do you guys want to do?
Give epi 1 to 1,000.
I like it, yeah, like an epi pen, right? Okay, what else? Just gonna give the epi and then stand back and wait for it to work? Pray that he gets better? What else? Fluids, absolutely. Definitely needs fluids. What else? Yeah, all the things that stop the allergic reaction from getting worse, right? So our first priority is epi-IM. We actually can go up to 0.5 milligrams in our new system. Oxygen, Duonebs, right? Albuterol and Atrovent to help the bronchodilation, right? Fluids, Benadryl, steroids. So we have 2 types of steroids in our system, dexamethasone and solumedrol, and you guys will learn about those as we roll those out. All right, another case.
Last one?
Yeah, please.
Use Pepsid.
Pepsid, yeah, you can. We don't carry it in our system. So Pepsid is an H2 blocker, whereas Benadryl is an H1 blocker. H stands for histamine, so you have the histamine type 1 receptor, histamine type 2, and so you want to hit as many receptors that are involved in anaphylaxis as you can.
That's what our protocol is now. We do
Oh, IV Pepsid or oral?
IV.
Oh, fantastic, great. Yeah, unfortunately we don't carry it, and I think that one probably does the least out of all of these. This is the one that makes the difference, right? These ones help later and probably short-term help.
It's on the bottom of the list.
Yeah, perfect, love it. All right, next case, 65-year-old female at home with family, third-story apartment, severe respiratory distress for 3 hours. Let's say they were having Thanksgiving dinner and she was eating all the salty stuff. And we'll maybe also say, well, I won't give away the answers. All right, what do you think about the blood pressure? Good, normal, high, low? Super high, right? AFib with RVR. Respiratory rate's high. Our SATs are low. Temperature is normal, so probably not pneumonia, not sepsis, right? Not with that blood pressure. All right, what do you guys think is going on with this patient? If you had to say, I'm putting my money on this diagnosis, at this problem, what would you say? It's okay if you don't know the answer. This is kind of advanced stuff, especially for EMT. Okay, yeah, so she could be an AFib that's causing her heart to not have enough time to fill with blood, so we can't eject blood, right? I like the analogy, right? If you got the hydrant going to the engine, you got a pump in the engine, right? And then it goes out to the nozzle. Well, what if somebody stands on the line going from the hydrant to the engine, kinks it, no blood into the heart, no blood out of the nozzle, right? Make sense? So that's how the heart works, it has to fill with blood first. And so if you only have a fraction of a second for it to fill and then it ejects again, you don't have a lot of blood going out. And so AFib with RVR is going to lead to a low cardiac output. So the periphery is going to squeeze to try to make up for that. But probably what's going on with this patient, overall clinical, if he had crackles in the lungs, swelling in both legs, right? Maybe they're on a medication called Lasix. That's probably CHF exacerbation. Jimmy, did you have a question?
No, I was just sitting here walking through this too.
Okay, great. All right, so, oh, sorry. What do we do next? Anybody want to give CPAP? All right. All right, so CPAP, why? Because it helps basically with anybody who's short of breath, right? It's going to help with CHF exacerbation. It's going to help with asthma. It's going to help with COPD. There's no reason to not go with this. It really would help this patient because this is kind of a picture for CHF exacerbation. Nitro is going to help us treat the blood pressure, decrease the preload on the heart, decrease the workload of the heart. Diltiazem, also known as cardizem, is going to decrease our heart rate and blood pressure. Labetalol will also do the same, but has more effect on blood pressure. So those are all medications that would be appropriate for this patient. All right, one more case. This is actually a cardiac arrest demonstration of high performance CPR that we did down in Seguin, who was one of our agencies that came on. This was their onboarding, or no, this is the Resuscitation Academy. And you can see that's their paramedic leading. You can see everybody has their spot and where they're at. There's Muscle, Northeim, and Lee Richardson. That's the guy that's gonna come for the third day. All right, 55-year-old male, cardiac arrest, got ROSC. Great, high fives all around. But, oh, here's our blood pressure, our heart rate. Ooh, man, I don't like that combination. Respiratory rate assisted via iGel and BVM. SATs are pretty good, glucose is normal. Who wants to load and go and get this guy out of here? Wrong answer, right? Stabilize before you begrudgingly mobilize. All right, we'll get it there. All right, you see an inferior STEMI on the EKG. Oh, all right, maybe that's why his cardiac output is so low. What do you do next? What do you guys want to do for this guy? Could pace the patient. Yeah, not give nitro. Ding, ding, right? Stay away from that. Yeah, you want this guy to go into cardiac arrest. Talk about a license to kill, right? Fluids, fluids, fluids. Increase the blood pressure, increase the preload, and that's going to help this blood pressure. Push dose epi is going to help with both the heart rate and the blood pressure, right? Push dose epi, little small pushes of epi. I like the idea of pacing, especially a push dose epi. I like epi first because it's going to treat both these numbers, but I like epi. And I like pacing too if they're not responding to it. Cool? Questions? All right. Remember, our goal is always to get our blood pressure above 90 and above a pulse ox of 94 before we move a patient. Stabilize before you mobilize, and the patient will not crash on you.
I don't know if you had said this before, but for best EMS for us coming on with our protocols, when you guys go through and review them, we are very aggressive in terms of we want you guys to practice medicine, to be in the field, to start the resuscitation and treatment of that patient, which will then continue on when they get to the ER. So that's not to say you're going to be educated, you're going to be trained, you're going to be checked off. It's not, we don't just throw the protocols at you and say go nuts. We want to train you guys up, but you guys have your EMTs and paramedics. We want you guys to use that knowledge and use that experience and that expertise and the resources that you have with you to treat these patients. You guys aren't a taxi service. You don't just load and go. That's not what we want you to do. That's not what you are. That's not what you worked hard to do all your education and training for. We want you guys to treat patients, make them better, resuscitate them, get them on the road to recovery so that when they get to the ER, they can continue that and on to the hospital and beyond.
Yeah, the goal is that when the ER doctor says, what did you guys do? And you've not left me anything to do because you did everything in the field, right? If there's anything that we can do in the ER, why can't we do that in the field is the question. That's a question we're always asking ourselves. And when we do that, patients get better. And then we get those survivor stories, right? Yeah, great point. All right, we're gonna talk about cardiac arrest, okay? Big concept. What is cardiac arrest? No pulse, right? Easiest definition. But there's different types of cardiac arrest, right? It's a common endpoint, but we can get there via multiple routes, okay? So we have two broad categories, medical and trauma. So let's talk about medical cardiac arrest first. So what causes somebody to go into cardiac arrest? There was no trauma involved, just medical cardiac arrest. What are the causes? Start naming them out.
Blockage.
Of?
The heart, artery,
You're not talking about like urinary blockage, right?
heart attack.
Okay, just, yeah.
vessel or artery.
All right, yeah, so coronary, yeah, that's actually the most common, right? So that's number one. CAD, coronary artery disease, buildup of blockage. Then at some point, one of those clots ruptures, platelets aggregate, clots appear, and then you get a STEMI, right, an MI. Okay, good. What else? Sepsis, can die from sepsis, go into cardiac arrest, hypotensive, tachycardia, vasodilation, infection. Finally, their body succumbs, multi-organ failure, right, all these things. Stroke, you can die from stroke. Seizure, prolonged seizure, you don't get there in time, you don't give them their Versed, right? They can go into cardiac arrest. GI bleed, you can bleed out. It's a form of hemorrhagic shock. So what do we do to treat these patients? Well, the only two things that have been shown to help with medical cardiac arrest are CPR, and we like high performance CPR in our system. And the other one is electricity, okay? Only two things that have been shown to have any significant effect on mortality: compressions and defibrillation. Guys, the EMTs in the room, can you do this? Do you own this? Absolutely, right? You can do this with an AED, and all you need is a little bit of training and knowledge, and you can make the most bang for your buck for that patient. It's not amiodarone, it's not intubation, it's not epinephrine. It's basic CPR, minimizing interruptions, doing high quality CPR. And we'll talk about what that means in a little bit. All right.
Resuscitation Academy out of Washington that I'm sure you already mentioned and I was talking about earlier. With them, with the highest ROS rates in the world, they are like 80 to 90% EMTs on their trucks. Okay? This is not something that is difficult to manage academically, right? This is stuff that we've been doing for a long time, right? CPR, first aid, good quality CPR, early defibrillation. That's what makes the difference.
Yeah, so don't tell me because you're an EMT, my highest training pre-hospital was EMT before I went to medical school. EMTs can do the most good for the sickest patients, okay? So you don't have to be a paramedic in order to do this. All right, now let's switch gears. You can also have no pulse because of a traumatic cardiac arrest. So what are the causes of traumatic cardiac arrest? Okay, good. Yeah, good. What else? Just picture somebody who had a trauma. We're not talking about psychological trauma, right?
Hypovolemic shock.
Hypovolemic shock, good. That's actually the number one cause is hemorrhage causing hypovolemia, right? Somebody's bleeding out. There's two ways to bleed out. You can bleed out externally, easy to see. The red stuff's on the ground. Put a tourniquet on, stop the bleeding, hold pressure, elevate, right? All the things you learned in EMT school. What else? Hypoxia, right? We just need to give them a little oxygen. Tension pneumothorax and cardiac tamponade. These are the four most common reasons why somebody goes into cardiac arrest in the setting of trauma. We use this term trauma all the time. What does it mean? Somebody define trauma for me. You guys want to take a crack at it?
External force, maybe?
Good, yeah, I like it, yeah. So like external energy being applied to the body causing injury. That's kind of the best definition I've been able to come up with. It's not years and years of wear and tear on the blood vessels finally reaching a tipping point and then you die. This is, I was doing fine and then a car hit me. And now I'm bleeding into my belly from a liver laceration. And I have a tension pneumothorax. It's not allowing blood to get back into my heart because I have tension physiology, squeezing of the input to the heart. And so I have no cardiac output. And all I need is somebody to come and treat that. So how do we treat it? Stop the bleeding, give blood, treats the first one, right? How do we treat hypoxia? Give them O2, non-rebreather mask, intubation. How do we treat tension pneumothorax? Needle or finger thoracostomy. Guys, do you guys know in our system as EMTs, if the patient's in cardiac arrest, traumatic cardiac arrest, can you do this procedure as an EMT? You can. We're gonna train you guys how to do it. You can put a needle in bilateral chest as an EMT in our system. And also do supraglottic airways, I-gels and those types. All right, and then of course for cardiac tamponade, pericardial centesis, we do ask if you're gonna be doing a thoracostomy, finger thoracostomy or pericardial centesis, that you go to cadaver lab and get checked off, and Jimmy will keep track of who's checked off to do these procedures. We're gonna try to get someone, at least one person on each shift to be checked off for these procedures before we roll it out. Okay? All right, prioritize procedures. Dr. Maynard, you're telling me that for traumatic cardiac arrest, you don't want us to do compressions? I thought you said compressions are the only thing that makes a difference in cardiac arrest. That's only for medical cardiac arrest. Why? Because the causes of medical cardiac arrest benefit from CPR. The causes of traumatic cardiac arrest are made worse by doing compressions. What if you're bleeding out of your liver? Now I'm gonna start pumping on your chest, causing more trauma to your, right? What is a tension pneumothorax gonna do if you start compressing the chest? It's gonna make it worse, right? You're gonna make their pneumothorax worse and you're gonna kill them faster, right? So we have to do a change in our mind. If it's a traumatic cardiac arrest, we now say, oh, no, we're not doing these anymore, we're doing these. And if they're not responding to that, then we consider doing compressions, okay? And I know somebody always brings up, well, what if you don't know? Could have been a medical or traumatic cardiac arrest. A guy who crashed his car, maybe because he had a stroke and then crashed his car. Maybe he had chest pain, had the big MI and crashed his car. Now you don't know if it's trauma or, those are few and far between, but we've had them. Use your judgment, treat the patient appropriately, okay? Make sense? All right, so we're running a little short on time, so I'm gonna kind of breeze through some of this, but just remember that compressions don't help with traumatic cardiac arrest. When you're doing compressions in a normal patient, you only get about 30% at max of normal cardiac output. And so this is even worse when you have hypovolemic patient that's trauma. So, and also you're gonna cause more damage. Okay, there was this cool study that was done on pigs. We're gonna kind of swing through this really fast. Basically, in phase 1, they bled these pigs out into a MAP of 45. It's a low blood pressure. about 30% of their blood volume. That's what we would consider the injury. And then in phase 2, they held them in this to allow for it to simulate shock. And then phase 3, they bled them out even more. They went into cardiac arrest. And then they randomized them into one of these 5 groups. Compressions with a Lucas device only, whole blood only, nothing else, just whole blood. Normal saline only, whole blood plus compressions, normal saline plus compressions. Which one of these groups do you think did the best? And then they looked at who was resuscitated. So here's the results. Anybody who got compressions died for the reasons we already talked about. So this is why we don't give compressions to traumatic arrest. It doesn't help and it probably causes harm. But anybody who got whole blood survived. Pretty cool, huh? Because we're treating the underlying cause. We're not just saying no pulse, compressions, no pulse, compressions. If it's a medical cardiac arrest, no pulse, do the compressions. You guys with me? All right, the bottom line, whole blood help these patients and closed compressions harm the patient. All right, here was a study called the PAMPER trial. This compares, if you look, PRBCs and plasma did the best, the least mortality drop, and saline actually was the worst, just saline alone. And so when a patient is hypotensive in the setting of trauma, they're in hemorrhagic shock, saline is not the answer. We're diluting their blood and making it less likely to clot. And remember, saline does not carry oxygen and does not have platelets and coagulation factors that help clot off the bleeding, okay? So that's why we're moving away from saline in the setting of trauma. So blood is superior to saline in the setting of trauma for hypotensive patients. Of course, we're not carrying blood, right? So just something to keep in mind. Maybe one day we will. STAMP trial looked at TXA versus placebo. Didn't show much of a difference, but it did show some benefit for severe shock if we give it early. Early is defined as less than 2 hours. So the bottom line on TXA is that it's safe and the benefits of severe shock, and make sure to give it early. The Deeb article looked at PAMPER and STAMP and did an analysis of both of them, and they came up with this thing called TERI, which is the time to early resuscitative intervention. So someone got injured, and then we either intervened pre-hospital or we didn't intervene, but then they intervened at the hospital, okay? So that amount of time, injury until we provided treatment, whether it's in the hospital or pre-hospital. That time, every 1 minute delay that we waited increased chance of survival by 2%. So the bottom line is that after about 30 minutes, you don't have much chance of survival if you don't intervene. So this could be giving TXA, this could be giving blood, this could be getting them to the hospital for the OR to fix their underlying issue. There's really no role for epinephrine in traumatic cardiac arrest. Why? Because the survival rate is worse. This is your survival rate with epi, and this is without. So by not giving epi, the patients do better in traumatic cardiac arrest, okay? You guys with me? I know I'm throwing a lot at you, so here's a summary, okay? Hemorrhagic shock, whole blood's better than compressions. PAMPER blood is better than saline. STAMP, TXA is safe, just give it early. Deeb, every 1 minute delay, we lose our chance of survival by 2%. Yamamoto, epi has minimal or no role in traumatic arrest. This is the European Resuscitation Council. So they say if trauma arrest, don't do compressions, but focus on the 4 things that actually kill patients in traumatic cardiac arrest. And what are those? Well, we talk about bilateral finger thoracostomies, getting the airway, controlling bleeding, pelvic binders, right, giving blood. And then if they don't respond to that, then consider terminating in the field. And we're going to talk about our trauma arrest protocol here in a minute. So you can either decompress the chest by using needle decompression, which again, EMTs can do only in cardiac arrest, or doing chest tubes, which of course we're not doing in the field. We're just doing finger thoracostomy. All right, here is our traumatic arrest. So we come on scene, there's a clear trauma, penetrating trauma or blunt, patient fell off a ladder, patient is in an MVC, which is probably the most common. Do you guys get a lot of penetrating trauma in this area? GSW, the knife and glove, gun club? Every once in a while, yeah. So anyway, patient is pulseless and apneic. If they're in asystole, what do? We don't resuscitate those patients. Traumatic cardiac arrest. GSW to the chest. Asystole on the monitor. We don't even work them. Why? Because if they're already in asystole by the time we get to them, they don't have any chance of survival. Now, if they're pulseless and apneic in the setting of trauma, and they have any rhythm but asystole, so this could be sinus tach, this could be a PEA, this could be VFib, VTach, right? Then we're going to do, based off of their injury pattern, if it's blunt trauma to the thorax, the abdomen, we're going to do our trauma procedures, the ones that we just talked about, right? We call it the 3-hole punch, bilateral finger thoracostomies, and pericardial centesis. Of course, all the airway, bleeding control, all of those procedures. For 10 minutes, and if they don't respond, then we stop, and we call that in the field.
Is that 10 minutes after all advanced procedures are done?
10 minutes of care with the patient, yeah.
After all advanced procedures, or just 10 minutes?
You have 10 minutes to do your procedures, and you'll find that as you get good with this, it takes you probably 2 minutes to do these procedures. Typically, the guy's on the ground, the guy who's on the right side of the patient does both right-sided finger thoracostomy and right pericardocentesis, or the pericardocentesis. The guy on the left side does the left pericardocentesis. If it's isolated, penetrating head trauma, GSW to the head, we can still do our resuscitation and then stop if there's no response after 10 minutes. Now remember, guys, if you're on scene and you're like, man, I don't know if this has fallen into the protocol or not, call medical control, okay? If you're uncomfortable, we're uncomfortable. Penetrating the trauma to the body, these are the ones that actually benefit from getting to the OR. So we actually change our tune a little bit and say early transport, and we're gonna do our trauma procedures en route. Whereas with all the others, we're staying on scene and looking for a response. That's the difference, okay? So just remember, penetrating to the body, these are our tension pneumothorax, right? These are our liver laceration. These are our whatever the case may be. GSW or stab wound or some type of penetrating wound to the body, these are the ones we're going to try to get to the trauma center as fast as possible. Do your procedures en route. Okay, questions on this? A lot of times this is a little bit new for people, so don't hesitate to ask questions. You don't have to ask now, you can ask later if you want, but all right. So this just goes through each one. So this is blunt trauma arrest, and it talks about all the things you're supposed to focus on as a checklist to make sure that we're doing everything, okay? And just a reminder that hangings, drownings, electrocutions, smoke inhalations, asphyxiation, these are all treated as medical, even though sometimes we're tempted to think like a hanging is a trauma arrest. It's not, actually. We treat it as a medical arrest. Still do compressions on those patients, okay? Also, it gives a mention down here. Epinephrine has no role in traumatic cardiac arrest for the reasons we talked about. They do worse, okay? Penetrating to the head only, these are the things you actually can do compressions if you're sure that they don't have any pathway of the bullet to the chest, right? So sometimes you get shot in the neck, it looks like a head injury, goes down, right? That's rare, right? But anyway, just keep an open mind. If you don't know the trajectory of the bullet, you don't really know if it's isolated head, but if it's pretty clear it's isolated head, you treat it like this. And here's your checklist for that. This is something that we'll print out and you can put in a laminated card in the back of the monitor or something that's handy. So that way, when you're looking at the patient situation and you go through and you say, all right, this is isolated head, traumatic arrest. What do we need to focus on? You pull this guy up and you say, did we stop the hemorrhage? Do chest compressions, manage the airway, give them blood. If you don't have blood, you can give crystalloids. As we know, it doesn't help, but that's all we have. Defibrillate if needed. Calcium and TXA are given just so that we can, calcium can get low, especially if the patient's gonna get blood at the hospital, so we can give it, and then TXA we know stabilizes clots, okay? And then it reminds you here, if no ROSC after 10 minutes, you stop the resuscitation. Do you have to call medical control at this point to stop the resuscitation? You don't. As long as you're following this, you do not. because it's laid out here for you on a checklist, okay? All right, and then here's the penetrating to the body, and it tells you there's nothing about compressions in here for that reason. So we try to make it as easy as possible for you guys. Follow the flow chart, get to your destination, and then you have the answers. Just follow the checklist, and we'll make these laminated for everybody to have on every apparatus so that when you get on scene, there's no thinking, you're not typing out, where the heck was that thing in the protocol? You've got it there in front of you, okay? All right, let's review. Causes of traumatic arrest, hemorrhage is the most common, it's about 55% of patients. Hypoxia is about 13%, tension pneumothorax about 10%, and cardiac tamponade is about 10%. You're probably saying to yourself, that doesn't add up to 100, that's okay. The rest are CNS. We can't do a burr hole or take care of a head bleed in the field. So those are the patients that don't have reversible causes for us. So we're just focusing on the reversible causes. How do we treat these? There they are, okay? And remember, procedures for traumatic arrest. Get an airway, give oxygen, right? You're just going down the list and doing all of these things. These are your trauma procedures. And don't give epi because it's probably going to cause them harm.